How does allergic rhinitis work? Well, basically, these little sort of grey speckles here are allergens. So, for instance, a grass pollen particle lands on the surface of your nose, comes through the lining, attaches to this thing called a mast cell. And mast cells contain lots of sort of goodies in them, including histamine, which is why we use antihistamines as a drug, because the histamine has very sort of profound effects on the tissue around it. It causes initial sort of swelling of the tissues, causes the blood supply to increase, and as such, it causes the nose to run, the nose to itch. And then some of the other chemicals get released, recruiting some different blood cells, including the eosinophil, which is a type of white blood cell. And this is involved in the late phase response, where we see congestion and sort of blockage as key features of the late phase response. So when we're looking at people in clinic, it's important for us to have a look in the nose. So in an ENT clinic setting, we'll use an endoscope to look inside the nose, see if there's anything else going on other than congestion, see whether there's any other misdiagnoses such as signs of sinus disease. One of the things we do, obviously, in terms of allergy testing is typically a skin prick test. You can see an example here. So we make some little marks on the forearm, and we drop some little drops of the things we're going to test for. So our common battery includes things like house dust mite, grass pollen, mold spores, cats, dogs, amongst a few other things. And then those get a little implanter, which sort of makes a small prick on the skin surface. And then the patients asked to sit in the waiting room for 20 minutes, and then they come back and we measure the size of the response. Now, I mean, maybe they don't get a response at all, but obviously if they do get a response, then that's usually indicative of allergy to that particular agent. We have what we call a positive and negative control. So if we implant water and their skin also swells up, then that indicates they probably got reactive dermatitis, and so we can't take anything from this result. If the histamine implanted provides no reaction, then we know this patient's probably been taking antihistamines prior to coming to clinic, and therefore we can't read anything into the result either. Other things might be done in a research setting, but we don't tend to do these things normally in a routine clinic setting. So allergic rhinitis has some guidance around the treatment for it, and usually based on the sort of severity of the case. So trying to decode some of the terminology on the side here for you. An oral H1 blocker is an antihistamine, so a lot of people will often sort of try things over the counter. So Benadryl, I guess, is a common one you can buy over the counter. Loratadine, cetirizine, often available over the counter now. In a sort of medical practice, we tend to often then move on to other agents which won't have been tried before. So fexofenadine is a key one that I find very useful to use in practice. Sometimes antihistamines can be applied locally. So there is a new spray now called Dymista. Dymista contains antihistamine, but also a steroid element to it. So it's a combined treatment. And then LTRA refers to a type of medication called Montelukast. And Montelukast isn't really a panacea for all cases of allergic rhinitis, but may be useful for people with quite marked symptoms who also have asthma. And then we sort of move up the scale. Sort of we can add in other sort of medications. Ipratropium is another treatment we sometimes use, and is also very useful for non-allergic rhinitis, particularly for patients with runny nose as a symptom. Allergen avoidance and irritant avoidance are obviously key things to help. If you can minimize contact with allergens, that's useful. There are measures people can do in the home to try and minimize the impact of house dust mite. And similarly in the summer, there are things you can do, such as avoiding hanging your washing out to dry outside and filling them up with pollen to try and minimize kind of contamination with pollens that may be provoking symptoms. Nasal douching is a very useful thing to kind of flush out pollen particles from the nose and other particles which may create allergy. And for patients with persistent symptoms, steroid nasal sprays really are the sort of mainstay of preventative treatment. In terms of desensitization in the UK, it's not a big program for desensitization. I worked in Canada 11 years ago, and all the patients there were getting their, what they used to call their allergy shots in a GP practice. In the UK setting, that's only available through a number of small selected centres around the UK, and is a program of either injections or tablets that go into the mouth to try and desensitize people. And that's usually done over 3 months and then repeated over a couple of years prior to the onset of the peak symptoms. And it tends to be for people with sort of single or one or two allergen sensitivities.
Take a spin.
Okay, so yeah, this is a sort of a miserable condition, and I'm guessing some of you obviously have been on the receiving end of this condition. There's a sort of classical picture that we see on a CT scan. On a CT scan, a sinus should look black because black is air, and you can see on this scan here that all the black around the side of this person's head is the air around their head. There should also be air in all their sinuses. You can see that this cheek sinus has got a little bit of air in it. The rest of their nasal cavity and their sinuses is pretty chocker full with swollen tissue and mucus.
This is a photo across here, is that right?
Yeah, that's right. It's like a slice through the head this way. That's right. So you can see the eye sockets here, and this is the nasal septum in the middle of the nose here. The smell receptors live at the top here. These are the cheek sinuses. These are the nasal cavities here, and it's all just obliterated with the swollen tissue and mucus. So yeah, CRS is a very common condition. Population studies that have been done suggested affects at least 1 in 10 of the population. Those studies are largely based on sort of questionnaires and reporting. So studies that have looked at actually examining people more carefully suggest it may be down to about 5%, but still that makes it a very common condition, and as common as many other sort of chronic conditions that are treated by the health service. It's very much a disease of middle age, so the average age of patients that I see in clinic is about someone in their early 50s. We do see people as early as sort of 10 years old and as old as 100 years old, but by far and away, most people are somewhere between 40 and 70 that come through clinic. There is a slight female preponderance, only very slightly. That said, when we talk about the different types of CRS, which we'll come on to, men are more likely to have polyps, and the women are more likely to not have polyps. This is a condition that affects quality of life, and studies that have been done suggest that quality of life impact is comparable to people with back pain and heart disease, so not insignificant issues. The key emphasis around CRS is that it is treatable, but not usually curable. And the earlier the intervention, the better the response in terms of treatment. So in terms of smell and CRS, so we did a big national study for which I was the chief investigator that we finished back in 2013. And this was a questionnaire-based survey of people attending ENT clinics around various centres in the country. And about 2/3 of patients on the symptom questionnaire that did as part of the study gave a score for loss of smell of being 2 out of 5 or more. So they had to rate things as 0 being no problem, 5 being a terrible problem, and you know, obviously the 1 to 5 in between. So yeah, so a score of 2 or more was rated by 2/3 of people. So a lot of people saying that smell loss was an issue, and in fact 1/3 of the people said that it was in their sort of top 5 complaints. And actually, when we looked, it was the second most common complaint after blockage of the nose. So how do we diagnose someone with chronic rhinosinusitis? So the person has to have had symptoms for at least 12 weeks. They have to have at least one of the symptoms of nasal blockage or congestion and of discharge from the nose. So one of these two. And then in addition, they have to have at least one of smell loss and or facial pain or pressure. Classically in chronic rhinosinusitis, it's more pressure than we see that pain. Pain tends to be more a feature of acute sinusitis. And when we see people with pain as a predominant symptom, it tends not to be caused by their sinuses. That has to then be confirmed either by findings on examination, so such as finding polyps or discharge, or evidence from a CT scan that the sinuses are blocked. So to date, we've largely categorized patients with CRS into one of two main groups. Those who form nasal polyps inside the nasal cavity, and for that matter, the sinuses, and those who we see are kind of discharging secretions from the sinuses that don't have polyps. Now, part of the reason for doing that was because polyp formation has largely to date been thought to be generated by a type of white blood cell that we mentioned earlier called the eosinophil. And in these cases, it's been thought to be generated by a type of white blood cell called the neutrophil. Now, as evidence has accumulated over time, we've noticed that that rule is not always hard and fast. And so some patients with polyps don't have lots of eosinophils. In fact, they have more neutrophils. And likewise, some patients who don't form polyps have more eosinophils. So we've now started to kind of move to thinking about defining patients on the basis of the presence or absence of the amount of eosinophils in their blood or in the tissue. Why do we get chronic rhinosinusitis? Well, that's a $64 million question. Unfortunately, we don't have any magic answers, but lots of kind of working theories around this. One of the theories in recent years is around biofilms. What is a biofilm? Basically, it's like a sticky sheet of bacteria, and all of you usually probably spend twice a day trying to scrub it off your teeth, otherwise known as dental plaque. So we think the same sort of thing sort of sits in the sinus cavities and therefore perhaps is more resistant to conventional treatment. That said, studies have found that biofilms exist in healthy individuals, and we don't quite know yet what the sort of interaction is to sort of make that problematic to cause CRS. We think in some patients, repeated colds, what we call URTIs, can occur without complete resolution between time, and so you get this kind of building. So you get a cold, feels like the thing's mostly gone, and then a few months later you get another cold, and that background level of swelling in the sinuses just slowly builds, and then you reach a tipping point, and suddenly the symptoms go from being every so often to being there all the time, and they don't go away. In polyp formation, quite a lot of research has been done around something called a staphylococcal superantigen. I'll come back to that in a moment. A2P is the word we tend to use around sort of allergic responses. I'll come back to that as well. There's the issue of the microbiome, which is a relatively new concept in sinuses, but you may have heard people talk about in the gut, good bacteria and bad bacteria, and this idea of probiotics. In a very few number of cases, we might find that there's a deficiency in some part of the immune system, so you don't have the antibodies to sort of to fight bacteria. And then we got the issue of aspirin sensitivity. So let's just sort of decode some of the medical terminology. So I mentioned sticky sheets of bacteria, that's the biofilm. We've talked about the cumulative effect of cold. So the superantigens is basically what happens is that Staphylococcus is a common bacteria that we often sort of get from patients' noses who have got CRS. And that bacteria can produce a toxin, so a chemical. That chemical can act as a sort of an allergic trigger, and it causes an allergic type of reaction in the tissue that causes the polyps to form. And so there's been some work looking around sort of how we might sort of counteract that. A lot of people have accused allergy of being a sort of causative factor for chronic rhinosinusitis. The reality is, and I'll show you some data on a subsequent slide, is that the fact that many CRS patients don't have allergies doesn't really give credence to that. And of course, as I mentioned already, allergies are quite common anyway. So we think now that allergies tend to exacerbate problems with sinus disease, but they don't necessarily cause it. The microbiome issue may be coming to the fore because of inappropriate use of antibiotics. So people are going to their GP with a common cold, saying that they feel that their symptoms aren't going, and they get given a prescription for antibiotics. And probably all that's really doing is knocking out some good bacteria inside the nose and allows the bad bacteria to take over, and therefore the bad bacteria then sort of run amok and start setting up shop and causing problems. So that may be an issue, and that's something we're investigating at the moment. the immune system is very specific and it's a very small number of people. And I think for people with problems that aren't responding to treatment, it's certainly worth having that checked through blood tests. Aspirin sensitivity affects about 10% of people who form nasal polyps. They also have asthma as well. And the reason this happens is that they have, for whatever reason, an exaggerated response to salicylate, which is the key ingredient of aspirin. Salicylate is also quite strong in concentration in certain vegetables, so grapes and tomatoes. And so these people will often sort of have worked out that a good glass of wine will bring about an exacerbation of symptoms. Although there is some suggestion that that may also be due to other ingredients in wine, such as sulfites and phenols. So it's not a hard and fast rule in terms of wine. But certainly salicylate itself, people have taken aspirin and they get either sudden sort of swelling of their nose, or they get swelling in their mouth, or they get wheezing in response to the problems with their airway, are typical sort of responses to in people who have got aspirin sensitivity. And their sort of version of chronic rhinosinusitis is much more severe and requires a lot more sort of help from the medical practitioners to look after it. I think one of the things to say about surgery is that unfortunately there is a huge amount of variation in practice and also variation in the rates of surgery done in the UK. You know, I sadly see a lot of sort of slightly kind of mangled looking insides of noses, and so the practice I do because of the people that come in to see me to try and solve their sense of smell issues. And you know, sometimes it's about the sort of the way the surgery is done. If the structures called the middle turbinates are removed, that can be particularly problematic because that is one of the receptor-bearing areas for smell. It also tends to mean that it can leave scarring behind afterwards. So this is a kind of a scarred-looking sort of olfactory cleft there at the very top of the nose because the middle turbinate has been removed here previously. And in patients who form polyps, what tends to happen is when they've had the middle turbinate removed, the polyps then try and sort of reform a middle turbinate, and they basically kind of block this space, so it all becomes a little bit of a nightmare. And this is an example from someone sent me these scans from Australia saying, please can you help me with my sense of smell? And unfortunately half the inside of the nose had been removed during the process of surgery, which is quite a sort of radical approach, I think designed to try and sort of alleviate the sinus problem, but unfortunately has robbed them of any chance of getting the sense of smell back. So it's pretty sort of sad to see that sort of event. It's also important, I would say, that you know, if you're seeing a specialist about this, to make sure that they've shown your scans to you and talked to you about what's there. I mean, this bottom right example is a patient who was seen by a neurologist 10 years before I saw them. And they completely overlooked the fact that the nose was full of polyps. They'd sort of focused on some minor issue on the scan and hadn't actually noticed the kind of obvious problem that was causing the smell loss. Actually, this patient went for 10 years with no sense of smell. Within 3 days of seeing me in clinic, had the sense of smell back because of some medication. So this was a very reversible problem, and it was sad that patient had to kind of walk around for a long period of time without that sort of treatment. I guess just to dwell on this side might be useful for a moment. So there are a number of reasons in nose and sinus disease why sense of smell may not be working. And we talked about this a bit earlier. You asked me about rhinitis, but we talk more generally, and particularly in terms of chronic rhinosinusitis. So if you've got polyps in the nose, obviously, as you can imagine, a polyp is a physical blockage. It sort of is preventing air going to the top of the nose. We mentioned also about the septal deviation. If that's present, that can cause a problem. The structures called turbinates, which are like cushions of tissue inside the nose, they can sometimes get very big, or they may anatomically just have developed with a space inside them called an air space. We refer that as pneumatization, and they may take up a lot of room and so be a physical barrier themselves. The lining at the top of the nose may itself become swollen, so the receptors tissue may become swollen. and you may get a lot of thickened secretions sitting over the receptors that's stopping the odors getting to the receptors. But when you get swelling of the smell receptor lining, obviously initially this may be reversible, but over time those sort of changes may start to kind of turn that tissue into the tissue that lines the rest of the nose, and therefore the functionality of that tissue may start to kind of ebb away. And also, if you've got sort of toxins in the nose, they may have a secondary impact and cause damage to the nerves, the smell nerves themselves, and stop them working. And sadly, I've seen some cases where to look in the nose looks like it's responded to treatment, it looks great, and yet the sense of smell hasn't come back. And that's because probably these people have been a long time with their condition, and it's just that those sort of injuries have occurred to the nerve pathways that are then irreversible, rather than the reversible elements which are happening inside the nose itself. There are sort of two key publications, and these are obviously very detailed publications, but there are summary versions that are freely available, certainly for on the Rhinology. If you write Rhinology International into Google, you'll get to the website, and you'll find there's a tab on the side that says supplements, and this is one of the supplements. And I think there is a summary version, and in that there are sort of flow charts which talk through the treatment sort of pathways that we've recommended. And I was part of the committee for EPOS 2020, which was a group of European colleagues that we all sat around and discussed all the issues around sinusitis and our advice and guidance on that as it stands at the moment in light of current knowledge. And there's also a sort of international, sort of American-based version on its way out, which is due out in 2021.
Thank you. So good to know that it's one of the key points of the sort of meeting points for in research. Okay, sorry, you keep coming across extra one. Go for it. What's your thoughts on this?
Certainly for all patients with CRS, nasal douching. I mean, it's a good starting point. It's also a useful conduit for other treatments, but in itself, it helps to improve mucus clearance, can sort of remove sort of thickened mucus and secretions, and obviously pollen particles and those that have allergies on top of that. All patients should also be on a nasal steroid, be it a steroid nasal spray or delivered within the nasal douching. Patients with polyps may benefit from a course of steroid tablets to try and sort of reset things. And in light of the superantigen theory, doxycycline given for 3 weeks may be helpful. The role of antibiotics otherwise is under question, and that's part of a trial that we're doing at the moment. So that's a group of drugs called the macrolides, and we're using something called clarithromycin. For patients that don't get on or don't progress with initial medical therapy, then the typical sort of process is to move on to sinus surgery. But sinus surgery hasn't actually been proven in a trial setting to be better than medical treatment alone, and is also under question in our trial. And then we've got the final thing, which is biologics, which are very new drugs on the scene. These are sort of antibodies essentially that kind of block part of the inflammatory pathway. And they're injections that are given fortnightly. Unfortunately, a course of treatment with these medications as it stands is about £10,000 a year. So they are not going to be given out for most people sort of anytime soon, but there will be criteria that are currently being looked at by the NICE committee to allow some patients to access those over time. Yeah, as I mentioned before, I mean, it's a chronic condition. It requires long-term treatment with intranasal steroids, and so sadly for most people, they've got to keep taking them. Are there any downsides to that? For most nasal steroids, no, they're safe to use long-term. Very rarely do we see any kind of complications of that. In the last decade, I've probably seen about 2 people among several thousand that I've treated that have seen any kind of side effects from steroids delivered just into the nose. Steroid tablets obviously have the potential for side effects, again, in long-term use. But most of the time when we use oral steroids for this condition, we're giving it in short courses for 2 or 3 weeks. And in that setting, the side effects usually are either mood changes or heartburn and indigestion. And most people usually will be able to tolerate those, and they disappear as soon as the treatment's finished. So yeah, I would definitely emphasize that if you need a nasal steroid, keep it going. A lot of issues around technique, and so important to try and get the technique right to get the best out of it. You can see on this slide here that we actually, as part of that questionnaire survey I talked about earlier, we're looking at patients who are being referred to an ENT clinic, and in theory, all patients referred in secondary care should be taking a nasal steroid and performing nasal douching before they come to us in ENT. And you can see actually only 18% of those with polyps and 12% of those without polyps were actually taking a nasal steroid at that point. So we know that compliance is a problem, and we know that it's not overly encouraged by GPs. So it's kind of my mission to try and sort of encourage people that they do need to kind of stick at these treatments. And even though they might not be enough on their own, obviously if they get other steps to the treatment later on, they need to always kind of have this in the background. So yeah, you may have heard this term functional endoscopic sinus surgery, or FES, sometimes ES, ESS. And these are all steps within that. So some people may just do this, which is just removing a little bit of bone at the side of the nose. Some people may open the maxillary sinus. Some people may open the ethmoid sinuses in part, in subtotal, in total. Some people may go to the sinus at the back of the nose. Very few people go into the sinus in the forehead. It's a bit of a feared sinus unless you're a sinus expert, and so it often gets missed. And there was a national audit done almost 2 decades now around practice in sinus surgery, and only about sort of 10% of people who came in for sinus surgery got their frontal sinuses operated on. And yet, actually, if you looked at the severity of disease on the scans, a lot of those people actually had problems in their frontal sinus. So it means that there's therefore potentially disease that isn't getting treated by the medical treatment post-operatively, and may explain treatment failures. So this is an example of a group of our patients, and sort of we can see here that this is their symptom scores, so on something called the SNOT-22 symptom score pre-operatively, and then we can see sort of after treatment, and so at 1 month, and then you can see there's a bit of fluctuation after that. And obviously, this is the kind of natural relapsing, remitting sort of disease condition, but we can largely, if they're looked after well, try and keep them below where they started. Oh, I think I missed out. So this is just a little video clip. So when I'm seeing someone in clinic, I'm sort of looking inside the nose and looking to see how their sinuses are doing, and you can see here a little bit of polyp there in that cavity there. Gives me a sense that their medication into the nose isn't quite doing all it needs to be doing on that side of the nose. Looking the other side of the nose here, I can see that these cavities here are looking quite open. The lining doesn't look particularly swollen. I can see up into the sinus in the forehead. As I swing my scope round, I can have a look into the cheek sinus, just coming up here. There, so you can see the little hole on the left of the picture there. So that nose on that side is looking pretty good. So on the whole, I'd feel that patient's medical treatment is probably doing most of what it needs to be doing. And if they feel symptom-free, then I'm probably happy that the combination of their feeling about the symptoms and my assessment of their nose is a good combination, and they're doing quite well. This was just really, a lot of people will come in saying, I can't smell and I can't taste. And the reality is that for 99% of people, they'll be able to taste perfectly fine, because tasting is what we do with the tongue. It's the salt, sweet, umami, which is savory sensation, sour and bitter. And that's from the taste receptors contained within the taste buds on the tongue. And the taste buds live in the side of the little bubbles you see on the tongue called the papillae. As Tom mentioned at the beginning, what actually most people think of as taste is actually sort of really about flavour perception. It's about this kind of breathing the air back out through the nose from the mouth, so actually kind of smelling the food that's inside your mouth. And if that's gone because your nose is blocked and you've got sort of polyps sitting here, that air's not circulating, and therefore you're smelling the aroma of the food, and it feels like a lot of the flavour of the food is gone, even though actually if you think carefully, it'll still be salty and it'll still be sweet and it'll still be bitter and it'll still be sour. All those things will still be there. Now, if those things aren't there, then obviously there may be an additional component to it. Distortions of taste may be caused by medications that are given. Some antibiotics can cause that, to give us a metallic taste. So that may be something to think about. Obviously, it may be that there is some underlying other medical condition which may contribute to true taste disturbance. But I say the vast majority of people, it isn't a taste problem, it's a smell problem.
So what if it is a taste problem? And I know it's probably more outside it's one you have to, of course, rule out. But if it is, any just
I guess it is, as a practitioner, if you're convinced that there's a true taste problem, then you can do a formal taste test and then look at any relevant investigations. Sometimes some blood tests might be useful to look at things like iron deficiency, vitamin B12 and folate deficiency, a number of small print causes, zinc deficiency, another one. So various metabolic reasons why people might get a true taste disturbance. But as I say, medications is often a key cause of that, and might often have it worth having a look at medications people are taking to work out if any of them are causing that as a side effect. No, so one of the big studies that has been done in the UK was the recovery trial, which used dexamethasone in patients with COVID and actually showed improved recovery. I think there was some initial kind of scaremongering about steroids having the potential to allow the virus to replicate faster because it's dampening the immune system. But that was some evidence from the previous SARS pandemic, and it's not evidence that's been replicated so far in the current pandemic. And so there isn't any suggestion that steroids are going to cause any problems. And in fact, we're certainly saying that intranasal steroids should certainly be definitely continued in patients who've got existing nasal problems and sinus problems. Standard nasal steroid spray should be prescribable by all GPs. So the common ones that I tend to use are mometasone, known as Nasonex, fluticasone, which comes as two different molecules. So Flixenase is one formulation and Avamis is another one. Those are probably the three most common ones that are available, and depending on preference and prescribing preferences, individual practices, they're all reasonably similar in terms of their effectiveness.